Okay, I'm going. All right. So chemotherapy is one of the cytotoxic systemic agents used in cancer treatment. Identify one side effect and one nursing intervention to address this side effect. So chemotherapy. So what is one side effect? You have lots to choose from. So one side effect, and then as the nurse, what are you going to do to address this side effect? Okay, you have lots to choose from. Make sure your nursing intervention addresses the one side effect you choose. Close the book. This is not an open book question. Lots and lots of side effects to choose from. Lots and lots. So your choice, and what would be your nursing intervention for that side effect? Okay?
Sorry, we just need the one.
Just one. One intervention for one side effect. And the intervention isn't necessarily to cure the side effect, remember? I mean, it's just what will you do to address that side effect. Okay, when you're done, I'll collect your cards. Thank you, thank you, thank you, thank you. And everybody is in their right little spaces. Are you in your right space?
Pink. Pink.
Pink. There should only be 6 at the maximum. You're all in the right pink? Oh, I can't count. Clearly, I need to go back to kindergarten. Clearly, I need to go back to kindergarten. Thank you. Thank you, thank you. Okay. Thank you. Any other cards here? Got a pile of them. Excellent, excellent. Yeah. Thank you so much. Thank you so much. Thanks, Prentice. Thank you. Okay. Any other cards waiting to come in? Okay, finish. That's good. And we need to get you guys closer, so maybe let's turn a table longwise. And then this way. And then you guys can join your group nicely. Those look really yummy. I'll do some, a little bit, not a whole lot. Most. If you what? Oh, I have no PowerPoint, so it's broken. So we'll go with So you're not going to see much anyway. Okay, do I have all the cards? Do I have all the cards? All right. Who would like to share what side effect they chose in an intervention? Yes. Alopecia.
And my intervention was a support group to help them through it.
Okay, excellent. That works. Alopecia, which is in layman's term? Hair loss. Hair loss in a support group. Yes. Little louder. Nausea. Nausea and vomiting. You can choose just nausea, but usually one follows the other, right? And what was your intervention? Yes, some antiemetics, and we talked about that quite a bit last semester, didn't we? And we actually went into quite a few of the drugs. That was one of our objectives. What? I saw another hand over here.
I did the same.
You did the same. Yes, that's yes.
Oh, I did the same thing. Nausea and antiemetic.
Yes.
Alopecia, but it said scarves and wigs.
Yes, excellent. Same problem with alopecia, but scarves and wigs. Right. What else?
Fatigue.
Fatigue, another big one. And what was your intervention?
Rest, plenty of rest.
Plenty of rest. Yes. What else?
I did hair loss as well, but I said to
Excellent, excellent, excellent. What else? Anybody else want to share? Yeah.
I think the same thing you said, the solution was advising them to go wig shopping now. Make it a
Yes.
fun day out for the girls.
Yes, that's right. That's right. Excellent. So you see, there's lots that you could have chosen from. Those are big ones. The ones that you did choose are really big ones. Nausea, vomiting, loss of hair, and fatigue are probably the three biggest, right? But there are lots of other ones that you could have chosen too. Excellent. So let me ask for some feedback. Are these out of line questions for you? Do you feel like I need to bring them more general, or do you feel like that these are good to get you thinking kind of things? This is what I want to do. I don't want these to be inappropriate. I don't want them to be questions that you feel like are not attainable. That's not my goal. And I'm not asking for a response now. This is something you can shoot me an email if you want, or send me an anonymous note if you say, Nancy, I don't feel like these are helping, and I feel like that these are things that I'm worried about the points, because that's not what I want to do here. I want you to start, just pre-thinking about what we're going to do in class. Okay? So if you feel like you're getting stressed about the points, then I'm defeating the purpose. So if you feel like these are not really getting you to pre-think about class, then let me know, okay? Because that's my goal, is to just help you get thinking about class. Okay. All right, so some general information about cytotoxic systemic agents, and because I don't have the PowerPoints, if you have the PowerPoints, you can follow along. The first slide, actually it's kind of the second slide of the ones I gave you, is just that general slide titled Cytotoxic Systemic Agent Therapy, and the slide itself says, analyze various classifications of cytotoxic systemic agent therapy, and identifying the various things that are come right off of your medication grid. But general information out of the book that I think is valuable are things like systemic therapy has many effects on normal tissue as well as on cancerous cells. Now this is different, right, from our surgery and our radiation, both of which could be considered local, right? Or targeted therapies, right? Okay? So we minimized with surgery, and with radiation, we minimized damage to the normal tissue. Chemotherapy or other cytotoxic agents, we don't do that, do we? Everything in the body, because it's systemic, that's your key phrase, systemic. It affects the whole body. So normal tissue cells are going to get affected as well. Agents induce cell damaging or cell killing, which is what the term cytotoxic comes from. So if you break that down, it tells you everything, right? Cytotoxic, cell killing. Actions on cells, including cancer cells. So we kill the bad, but we also kill the good. Selection of agents is based on cellular kinetic concepts. So cellular kinetic, the kinetic, think of that as movement. Kinetic is the movement, the action part of the cell. So we're looking at cell cycle, growth factors, and tumor burden, or how the tumor actually works and grows. So those are the things that the cytotoxic agents are going to work on. Most of the cytotoxic agents are not cancer cell specific. Now one category, can anybody tell me of the categories, which one do you think is cell specific by its title?
Anti-tumor agents.
A little louder?
Anti-tumor agents.
No? In its title. Title tells you everything? Targeted, that's it. That's right, targeted. It tells you in its title that it's targeted. But the rest of them are not cancer cell specific, okay? So they're going to potentially affect all cells in the body. The most susceptible cells are those that rapidly divide. And those include, we're going to come back to that statement again, but bone marrow cells rapidly divide, so they take a big hit. with cytotoxic agents, bone marrow. And so you're going to see a lot of the side effects or complications from cytotoxic agents relate back to bone marrow problems. So if you think through, one of the things that I really stress to the students as you're learning, if you think through the why or the rationale, it makes learning new material that much easier. So if you know that rapid dividing cells take the biggest hit, and bone marrow is one of them, when you look at side effects and you look at complications and you remember that, it'll make a whole lot more sense to you when you look at complications and side effects. Oh yeah, that relates to bone marrow and that takes a hit. That makes sense that I'm going to see these signs and symptoms and these complications. So try not to just memorize, you guys. Try to put the why, the rationale, with what the problem is. And it'll stick better in your mind instead of just memorizing. Make sense of it. Okay? All right, so now we start the group activities. So the reason I put you in groups is I want you to look, get out your medication grids. I'm hoping somebody in each group, or maybe all of you, which would be fabulous, did your medication grids. If not, get your book, because everything you need to do this activity came out of that book. If you don't have it on your grid, that's okay. This activity is going to help you build that grid. If you did your grid, fabulous, then you don't have to have that big bulky book in front of you. But I want this to be a group activity, and you're going to each get one of the categories, and there may be a little overlap here, but we're going to discuss it as a group. What were some of the key? I have done my work and went through the book and built my slides and all of the areas important. So what I'm going to do is, after each of the groups do theirs, I'm going to go down and check mark, and anything that was missed, I'll contribute, okay? So by the time we're done, we as a whole group will have all the important information, okay? All right, so I think we're going to have these guys do chemotherapeutic at this table. This table is going to be doing immunologic or biologic response modifiers over here. In this back group over here, you're going to do targeted, okay? Hormone manipulation. And this group is also going to do chemotherapeutic. So we'll have two groups doing chemotherapeutic.
And you just want us to complete this?
Yes. So if you have your medication grids, compare and contrast. Make sure all of the information is done. Those of you who don't have your grids, use your books and compare and contrast. Has everybody heard me? Yes. Okay, excellent. So I'm going to give you at least 15 minutes. I'll touch base and see how you're doing. So those of you who did your grids, compare with those who are pulling out of the book. Remember my key, don't rewrite the book. Just pull out the important points. Okay, go for it. Good. While you make sure you write this down so you can, if you haven't got your grids done, you can get them done today. Excellent.
Yeah, table 22.5.
Okay, good.
So it has the action was modified patients biological foster tumor cells.
Excellent.
Includes immune functions.
Nice job.
Yeah, so the difference here, the sargram mostly, if you go to general.
And the thrombocytopenia?
I
Okay, good
Yeah, all
job.
that, neutropenia, thrombocytopenia is on every, all of
Is
it.
that the information or is that?
Did you find that on here?
What did you say?
When you look at the common medications in each category.
So good. Get your grids done today while you're working. Take advantage of the time.
The first one that is TKI.
No, my question is, actions, we all have different actions.
Yes, yes. Okay, you guys have the targeted ones. I'm going to interrupt. You guys have the targeted ones. I will not test to those specific subcategories, okay? So in a way you have it a little bit easier because I am not going to test to those specific subcategories, okay? So in a way you're just going to say it depends on those specific subcategories, so your side effects and your nursing implications will be based on those specific subcategories, and leave it at that. Because there's too much specificity, and you're not going to need that until you take care of a patient and you know what they're going to have.
So with the targeted ones, me and Taylor were talking, we had a hard time finding the contraindications. Would it just be allergic reaction?
Honestly, all of them have very little to speak to contraindications.
Yeah, that's the only thing I saw was allergic
I couldn't
reaction.
find anything.
Yeah, and there's very little in this book about that. So skip that one and go on. And yeah, the bulk of the things you're going to find are like action. In the other ones, you'll see a lot about side effects and nursing implications, general information. But you guys have probably the least data available. Okay, so all of you guys, do you have yours on your?
Yeah.
Okay, so the rest of you take advantage of the time and try and fill in. Okay, good, because all of you, yeah, use your book. And again, remember, don't rewrite the book, but get your grids done today if you can.
I know, like, under action, I put
Now make sure you guys talk about it so that you're not writing too much, okay? Yeah, touch base with each other on what you want to say.
So by reducing that VEGF, the tumor starts to.
So this is under action. Oh, for action, okay, so for general, okay, so there are. I do have for two. I do for two, yeah. But we did have
Or
there's the two that you're, the one that you're talking about, the Brita, therapy. That's on 375. 48 hours. Oh, that's radiation though. But radiation is different. I don't know what the radiation would be. Oh, no, you're
Reduces the levels of tumor-secreted vascular epithelial growth. So that's the one that's a little bit different. It affects the tumor rather than enhancing the body's response to it. That's the only little difference.
So it finishes the growth factor.
It's on page 387 right
And
after.
the action is what? Action is how it works in the body.
Synthesis.
So like my action.
Oh, I thought we were getting that. So we're just supposed to put the general information on the chemotherapy. I'm not supposed to do it for each particular single.
Right,
Yes,
That's right.
right. So yeah, you just do it for that, and then you go into your actions for each one. Yeah. Mm-hmm.
Okay.
Yeah.
Thank you.
Yeah.
I put that they mimic metabolites.
And then I think everybody got that, the major side effect was severe inflammatory response. Which resulted in big cerebral edema, these patients have to be in ICU care. I think it's happened a lot. If you didn't get it in here, because it was only B was in the drug guide. What is it?
Intestinal obstruction or perforation.
Okay, caution. I will not test out of the David's jug ride.
Okay, so it's in the book?
Whatever we need to know is in the book.
It's in that textbook. So don't confuse yourself by going to alternative sources. Okay? So, I mean, good for you for going one step further, but in terms of being able to answer test questions, it's going to come out of your med-surg book.
Did anybody find any contraindications?
Yeah, and I didn't either.
Okay.
I didn't either. Now, the reason I put that box is because that's what the objective said. So when I created this document, it came from the objective. And then I went to fill it in, just like you go to fill it in, and I couldn't find anything.
Well, the cool thing is it says you have vivid dreams.
Yeah.
Nature abhors this void.
I know. I agree. I agree. And I searched high and low for contraindications. So we'll talk about that.
We don't have cancer.
You know, one of the things that we can do is when we research a topic, then we use our own intellect and think about it and go, what would be a contraindication? Okay?
Okay.
Exactly. Yeah.
Yeah, allergic reactions are side effects. Skin dryness, itching.
Yeah.
The side effects are so severe that it's
Or
outweighing the benefit.
what would be just your basic knowledge about somebody who has cancer? What would be a contraindication for any chemotherapy? They catch a cold.
Oh, because their immune is down, so.
Would we do a round of chemo?
Immunocompromised.
Yeah.
Okay.
No, we wouldn't. Okay? So the reaction is so severe that they go into one of their side effects to the point that it shuts the system down. No, we're not going to do it. So, you know, we walk a fine line of teaching you guys all of this data. Sometimes I think we teach out the critical thinking because we're so focused on all this data that I like to step back and say, okay, let's stop a moment and look at all of this data and what would your common sense tell you? That's what I want to do with the contraindication boxes. Because they don't spell it out in the book, but you're an adult learner. You know that there would be situations where you'd say, Doc, this patient is so sick. One more round of chemo and they're going to KO.
Yeah.
Yeah. Yeah.
Maybe I'm not reading this right, but
No,
for the
what?
contraindications,
Yeah. I just had that conversation.
Okay.
I could not find contraindications in the book for any of these.
yeah.
Yeah, so we're going to talk about that separately
Okay, 'cause
when
I'm
we
like,
get
oh
there.
my God.
I know. Like Eileen said, you know, an empty box is, nursing students just can't have an empty box. You know, something must go there. So what I did is I created that box before I actually did my own filling in the blanks, and I couldn't find contraindications for any one of these. So we'll fill that in.
Okay.
Yeah.
Thank you.
So you keep going. Allow there to be a white space. Yeah, so you guys keep going past that contraindications because there's very little to find. in this book about contraindications. And it's allowed to stay white. Oh, good. You guys skipped contraindications because there's virtually nothing in this book about it.
Question. So it says like some of the side effects of these drugs are masculizing effects on women. Do women who are trying to become men take these drugs?
You know, that's an excellent question. I don't think so, though, just because there's such ugly side effects. There's other types of, I mean, testosterone can do the same thing without
okay.
the bad side
I
effects.
just didn't know if they like were desperate and like
No.
they do.
One, I don't think they can get their hands on,
Oh, okay.
number one. Because, you know, chemo is really,
I know. I'm like,
yeah, yeah.
Okay.
But testosterone's a whole lot easier to get a hold of.
and testosterone will do all those same things.
An awful lot of that,
Okay.
yeah. Yeah. Okay, how are we doing? Good? You're progressing. What box are you on?
Me?
All of you.
I'm already done with it.
Well, la-di-da, excellente. Oh, yeah, you just swing that little lanyard, Batman. Now, you going to bring the rest of your colleagues along?
Yeah.
Okay, good job.
And this just has one little bit after each one.
Okay, how's everybody here doing?
So
Good,
for,
good,
of course,
excellent.
you know, antiemetic for nausea.
All right, well, have your colleagues help you. You're not in a vacuum.
Yeah. And after each
How are you guys doing? Good, okay. Getting what you need with these?
I have a question. Side effects, they all have different ones.
Yes, they do. And so you're just basically going to put that it depends on the drug that's given, and the same for the nursing implications, because they're all different. And I am not going to test you to those specific drugs. They're just one, you don't need to know that at this point.
So we just need to know what could happen. It doesn't matter which one you're taking.
You just need to know it's specific to the drug for side effects and nursing implications. Now, there is another statement on a previous page that has a general nursing priority. Did you find that statement on the previous page?
It just says that it's important to remember that these drugs will not work unless the cancer cells are expressed.
You have it highlighted. What does that say?
Careful assessment for adverse reactions to therapy.
That's all you need to say under your nursing interventions, because clearly that sums it up for all of them, doesn't it? Say it louder for all of them. Because that's clearly the key. It's the key. Okay, how you guys doing? You getting close to the end? Okay, excellent, excellent. Can everyone finish in another 5 minutes, do you think? Yeah, that was a yeah with a question. Can you guys finish in another 5?
Good. So when I
Okay, how about this back group, another 5 minutes, you're good? How about you guys, 5 minutes, you're good? Okay, all right.
First trimester pregnancy is generally a contraindication.
Are you getting this from the book?
No.
Then don't bother.
I want to know.
Okay, well, it's fine, but don't muddy your waters, because the test questions are coming from your book.
Yeah, I did.
I'm not trying to squash.
That's okay. I did
In
find
co-
the indication, so I wanted to know what.
Okay, okay. And that's, nice, but don't, because sometimes that can get in your way. But it's always good to have an inquiring mind.
which I highlighted previously. But I just never built this in. But yeah. Well, yeah, I mean, I guess those are like interventions. You said massage. Distracting. Right, imagery.
Okay, another minute, and then we'll come back as a big group.
What about like administration of antiemetics?
So let's do those. Those were more like non-pharmacological, but then for Tuesdays are my days. Not busy yesterday.
You would still want to watch
Because it could be a sign of something else, they won't tell you what the sign of. Yeah. It just says infection. Oh, it's infection.
Okay, finish up. We're gonna, because I still have a case study for you guys to work on, and I don't want to leave that. Okay, so let's start with our chemotherapeutic groups. We have two. So I'll bounce back and forth between the two as they fill in. So let's start with general information. And remember, I am taping, so you don't have to madly write stuff down. Okay, so this will be posted on YouTube for taping. All right, so this group, what general information did you guys pull out of the text?
It's the treatment of cancer with chemical agents.
Yes, okay, what else?
Tumors with rapid growth are more sensitive.
A little louder, please.
Tumors with rapid growth are more sensitive to chemotherapy.
Okay, good. And what about this group over here? Any additional general information you want to share?
Systemic.
Loud.
It has a systemic effect.
Yes. What else? Anything else to add? Anything over here in general? Okay, so things I'll add to the mix. It's used to cure and increase survival time. It can also be considered an adjuvant therapy, which means what? In combination with something else, correct. It's got multiple drug classifications because, as you other groups know, you're working on them. And it has specific actions. Table 22-3, page 378 goes into those different classifications, but you guys are working on them, so you already know that. Okay, action. Let's start with this group over here. What are the actions of chemotherapeutic drugs? What did you guys come up with actions? Somebody want to share that? No?
Disrupts DNA and RNA synthesis.
Yes, it does. Good. Damages DNA, interferes with cell division. What else? We already mentioned that it hits rapid growth, it's more sensitive. We already mentioned that it's a systemic effect and that rapidly dividing. So I have that under action. And the rapidly dividing includes skin, hair, intestinal tissues, spermatocytes, and blood forming, which is your bone marrow. Okay, so I put all of that under action. All right, side effects. Let's start with this group with side effects.
There's
Loud, Marvin?
Yeah.
Loud.
There's many of them. So there's hemorrhagic cystitis,
Yep.
cardiac muscle damage,
Mm-hmm.
loss of bone density.
Yep.
Then there's some serious side effects that are short term, which are your anemia, neutropenia, thrombocytopenia, and then there's nausea and vomiting.
Mm-hmm.
This one are the common distress and side effects.
Yes.
So there's nausea and vomiting, alopecia, mucositis.
Mucositis, yeah, mucositis, which it sounds just like it is, mucositis. What do you think that is? Mucous membranes, right, very good. Keep going, sir.
Okay, many skin changes,
Uh-huh,
anxiety,
uh-huh.
sleep disturbance, altered bowel elimination, and changes in cognitive function.
Excellent. I think we might have hit them all, but do you guys have any to add over here? Okay, so I'm sorry? Yes, yes, thank you for adding that. Dry mouth is a big one, yeah, okay. So the bone marrow, neutropenia, thrombocytopenia puts them at a major infection risk. So all of those are absolutely correct, and it puts them at a huge infection risk. The anemia, thrombocytopenia also puts them at impaired clotting. And I think the rest the other one, I don't know if we got this one, so correct me if you did. The chemotherapy-induced peripheral neuropathy is the only other one I don't think we got. Yeah, okay, good. All right, nursing implications. This table here, what do we got? What are some nursing implications?
Non-pharmacological would be like distraction, massage, guided imagery.
What else? Good.
Temperature for the sign of infection because it might not show up other places.
Excellent. What else? Loud, loud.
Administering antibiotics.
Yes?
PPE.
Yes, what's the PPE for, please? Hmm? Okay, say that nice and loud.
The chemo can transfer through your skin, so you need to gown and double glove.
To protect the provider. Yes, and along that same line, what is the criteria for the person giving the chemo? Can anybody? You have to be trained and certified. Only certified RNs can give chemo. Did you guys have that and I didn't give you a chance? No? Any other nursing interventions, this group? Hmm?
Prevention.
Prevention of? There's a big one. Can you link that to a really big problem? Hmm?
Infection. Prevention.
Say it loud. Extravasation. What's extravasation? It's nasty. What's extravasation? Infiltration of the tissue around it. There's a lovely picture in your book. Nasty, nasty, nastiness. This is poison, you guys. Chemo is poison. It's nasty business. And if you don't have a good vein and it comes out into the tissue around it, it kills, remember? It kills good, healthy tissue as well as the chemo. It destroys that tissue. It's nasty business. So prevention, which you were on the right track, of extravasation. Okay? I think, so one of the major nursing interventions is to prevent injury and promote safety. Yes?
I just wanted to share an experience I had this
Okay,
summer.
nice and loud for everybody to hear.
An experience I had this summer. I worked for a group called Homestead. It's not nursing care, it's just, anybody like me going to take care of people. And I had an Alzheimer's patient who had a cream, and he gave it to me, said, can you smear this on my shoulders? I've got some sores here. And I looked at his shoulders, and they were like scabby. And I looked at this cream, I didn't recognize it, so I looked it up in the Davis Drug Guide, and it was a chemotherapy type of cream. And I said to him, just reading about this, I think those scabs might be from this cream. Which doctor prescribed this? He was like, I don't know, 12 years ago, but I got psoriasis now and I need it on my shoulders. So I said, why don't we go to the clinic and just find out what the doctor says. And the doctor confirmed, like, yeah, you definitely should not be using this. You know, go contact the doctor who prescribed it.
Good call, huh?
But it's just
Yay! Good call.
If I didn't have any nursing training, I would have just smeared the cream on, you know, right? The patient.
And good thing, if you had no gloves, hello,
Another thing.
hello. Good call, really good call. So yeah, excellent. You know, and I bet if you went into even your parents' medicine cabinet and under the sink, you might be a little surprised what you'd find. Ma, what is this stuff? Well, I got it. My neighbor said it's really good stuff. You're like, holy guacamole. You can't have this stuff. My mom's a nurse and she shares meds. I'm like, Ma, you know better. Yeah, it's pretty scary out there. Okay, so a couple of charts in your book that I did not take the time to write out because it's gosh darn too much information. But chart 22, 3, 4, 5, 6, 8, and 9. I don't expect you to read and memorize these charts. Don't be ridiculous. But I do want you to read them for general knowledge. There's lots of teaching that we do with our nursing implications, okay? It goes from page 382 to 386. And there's lots of information about if they have reactions and what the nursing implications, okay? Those of you that are going to be on oncology, I chose to put this section early in our lecture so that you would be very prepared when you got on that oncology unit. So this is good information for you for hitting the ground running next Thursday, okay? So take advantage of that. All right, so now let's go to the biologic response modifier group, which is right here. Let's hear what your general information you have to say.
So the BRMs, the biological response modifiers, modify the patient's biologic response to tumor cells. Some agents stimulate specific immune system cells to attack and destroy cancer cells, and other agents block cancer cell access to an essential function or nutrient, causing its elimination.
Excellent. So what you just heard definitely comes from its name, right? Immunologic. So instead of memorizing, let's connect the dots. Immunologic, and just what you heard makes sense, right? Okay, good. Anything else? Okay, what I would add to that is that it can interfere with cell differentiation, transformation, and metastasis. Okay, so that might help a little bit too with understanding how it works. You could have also put that in action, so it could be general information or it could fall under action. All right, let's move on to action. What do we have here?
It slows tumor cell division. It stimulates growth and activation in the NIC cells, induces cancer cells to resume their normal appearance.
Okay.
It inhibits the expressions of oncogenes.
Okay. Okay, a few things that I will add. That's all very good. What I would add is that it stimulates the immune system to recognize cancer cells and take action to eliminate or destroy them. Some BMRs stimulate faster recovery of bone marrow function. Remember, that's one of the fast-acting cells, or rapidly reproducing, excuse me. And so it stimulates faster recovery. So that should make sense. Knowing that bone marrow gets a hit, it can stimulate faster recovery, which is important. And then there's two kinds. You may have put this lower down. And so I put it in action to speak to the action. So interleukins and interferons. With interleukins, it helps different immune system cells to recognize and destroy abnormal body cells. Interferons, they assist cancer therapy in various ways. One way is to slow tumor cell division. So she said that. I just chose to differentiate between interleukins and interferons under action, okay? So this was discussed. I just narrowed it down. All right, side effects. What do we got with side effects?
Severe inflammatory response.
Little louder, if you please.
Severe inflammatory response, capillary leak syndrome, which is edema, flu-like symptoms, general malaise, and these patients need to be cared for in ICUs. There's also a neurological manifestation of this drug.
And skin. The only other thing I'd add is skin dryness, itching, and peeling. Now, a few things that I would, everything that was said is absolutely correct. I will elaborate a little bit in that the big thing here with immunological, you can link it again. That makes sense. That falls out that you have an inflammatory, severe inflammatory reaction. And with a severe, we talked about this last semester, so you guys know all about the inflammatory reaction, right? Say yes and you're correct. Fluid shifts, edema should fall right out of that because that's exactly what we learned last semester. Okay, so we have the fever, chills, rigors was another one that it was talked about in there. The neurologic signs and symptoms now can be significant where they have confusion, fatigue, somnolence, irritation, agitation, hallucination, vivid dreams, anxiety, and sleep disturbance. So you might think this person is crazy, has some serious mental defects, when in fact it's the medication they're getting, okay? So you need to keep your eye out for these severe, and the family may need to be educated on the fact that, oops, I'm jumping ahead, my bad. But that these expectations of neurologic disorders are because of the medication, okay? All right, and then the dry, itchy skin, that's definitely one of the things that we can do something about. So nursing implications, what do we got?
For the skin, advise patients to apply moisturizers unscented and to use mild soap to clean the skin and to protect areas from the sun with clothing or use of sunscreen agents.
Absolutely, and stay out of the sun, okay? Which is key here, right? It's a rare day, on the day we have an eclipse, that we have clouds and rain. The one and only day, right? Okay, what else?
Antiemetics for nausea.
Yep.
Look out for the early identification of neurologic problems.
Yes.
Teach to avoid swimming.
Yes.
And avoid topical steroids.
Yes. Now, what are some other medications you can anticipate to give them? Acetaminophen for
Fever.
and comfort, and
Meperidine.
meperidine for
Rigors.
rigors. Right. You don't see meperidine, and that's one I might actually question. When you actually take care of somebody in the hospital, it's rare these days that we use meperidine. It is Demerol. But we don't, it's rare to see Demerol used anymore. So I just would put a question mark there. If you take care of somebody, and those of you on oncology, could you explore that for me? See if they even use Demerol anymore.
What else would you use for rigors?
I don't know. That's a good question. Because Demerol breaks down its half-life. When it breaks down, one of its byproducts is very toxic to the system. It builds up in the system. And they stopped using Demerol a long time ago, and it went to morphine and Dilaudid are the typical drugs of choice because the half-life, when one of the byproducts of Demerol builds up in the system, and it's very toxic, especially for our older population. So I was really surprised to see Demerol in this text. But you know what they say about texts. As soon as they're published, they're outdated. So those of you on Onc, if you could explore that for me, I'd really appreciate it. Yes?
So the other thing that Shannon found in connection with that, using Demerol to treat the rigors, is that you have to be very careful because the rigors can be a sign of another problem like infection.
You know, with all of these, when you use medications, that is a true statement for any who especially immunological, where you could mask other signs and symptoms. And we learned that last semester, where especially with what other category of drug?
Over the counter.
Nope.
The
Other?
antacid.
What other category of drug does a wonderful job of masking other signs and symptoms? Steroids. Steroids are huge at masking other signs and symptoms. Okay, excellent, excellent. I'm brushing away cobwebs. I feel cobwebs going away one at a time. Okay, targeted therapy, this group back here. So what's some general information about targeted therapy? What do we got?
Target specific types of cancers.
Okay, nice and loud, please.
They target specific types of cancers
Yes?
and the specific attributes of those cancers.
Okay, good. Anything else?
They use molecular flaws.
Nice and loud.
They use molecular flaws to
Yes.
target cancers, and they bind to proteins, and they will not work unless the cancer cells overexpress the targeted substance.
Very good. Did everyone hear that? Okay, so we need to say it really loud, like you're talking to your kids.
They use molecular flaws to bind to target cancers. They bind to proteins, and they won't work unless the cancer cells overexpress the actual target substance.
Okay, excellent. Good. All right, what's some actions that we know with these guys?
They won't work on every type of cancer.
Right, they don't work on every type of cancer. What else?
They do work by blocking growth and
Nice
spread.
and loud.
They do work by blocking the growth and spread of cancer by interfering with specific signals or molecules involved in the growth and progression of cancer cells.
Excellent. Okay. So a full explanation of this process is discussed on page 388, and it's an FYI. They do a really nice job, and they show you a picture of it, but I am not holding you accountable to this very detailed explanation. But it's a great explanation of how this all works, okay, if you're interested. Okay, okay, what else do we have?
That's all I have.
How are these drugs classified? There are multiple drugs. They're classified by mechanism of action. And you can see that on table 22-6, page 390. So the last two sections, side effects and nursing implications, I'm going to let this group explain it to you. What do you got for them?
Oh, I'm sorry, what, nursing implications?
And side effects and nursing implications.
Side effects depends on the drug given.
And
Um,
a general nursing implication, and then
nursing implication will be careful assessment for adverse reactions to that given therapy.
everyone hear that? Yeah? Nope. Need nice and loud.
So, nursing implications are careful assessment for adverse reaction to that given therapy.
Right. So with targeted therapy, it's a relatively new therapy. And because it is targeted, what does that word mean to you? Specific, that's right. So I told this group, and they learned while they were doing their research before I even said anything to them, that there are subgroups in targeted therapy. The side effects and the nursing implications are very specific to those subgroups. I am not expecting you to know those subgroups. So the side effects and the nursing implications are specific to those subgroups. So the general nursing implications are what was identified, that you monitor the patient and it's specific. The priorities are to watch for adverse reactions for each patient based on the drug they're getting, the side effects, okay? So targeted therapy is a little different than the others because it's so highly specific based on the type of category of drug. Now, if you look at your objectives, you will see that you do not have to know specific drugs, which is why I am not expecting them to go through that detail or you to know that. All right, our last group here, hormonal manipulation. What's some general information?
Some tumors require specific hormones to grow, so suppressing said hormones
Can everyone hear?
Some tumors require specific hormones to grow, so suppressing those hormones can slow the growth of the cancer. It's not a cure, but it's more control.
Yes, that's the key here with hormonal manipulation. They're controlled but not cured. Okay, what are the only other thing I added here were their steroids, steroid analogs, and enzyme inhibitors. And the other problem we see is some hormones make hormone-sensitive tumors grow more rapidly. So that's the downside if we don't get it right. Okay, what are the actions?
Agents are used.
Nice and loud.
Agents are used to block receptors and prevent the cancer cells from receiving normal hormonal growth stimulation. So an example of that, I don't know if I'm saying this right, aromatase inhibitor prevents the production of estrogen in the adrenal gland and reduces the blood level of estrogen, which results in slower growth in some breast cancers.
Correct. That's a correct statement. Yes, and that's
an example.
That's an example. Correct. Okay. All right. What else is another action?
Agents inhibit normal organ production.
Nice and loud.
Agents inhibit normal organ production of specific hormones.
Okay. And there's another action. Some drugs are hormone antagonists that compete with natural hormones at the receptor. They bind to the specific hormone receptor and prevent the needed hormone from binding to the receptor. In other words, they get there first, and that antagonist takes over the receptor, and there's only so many receptors, and then so the antagonist slows the tumor growth. Okay, side effects. What do we got? There's some very interesting side effects. What are they?
There's two different kind of classes.
Okay, nice and loud.
So for androgens and anti-estrogen receptors, those will have masculinizing effects in women. So chest, facial hair, no more periods, fluid retention, acne, and then hypercalcemia is common with those drugs, and liver dysfunction with prolonged use. And then with estrogens and progestins, those have an opposite effect. So those have feminine manifestations in men, and again, different or opposite from the androgens. It causes bone loss, so osteoporosis and fractures and stuff. So the patients are at risk for those. Irregular periods, fluid retention, breast tenderness, and an increased risk for thromboembolism.
Correct. Okay, so women start to lose feminine effects and start to look more masculine. Men lose masculine effects and start to look more feminine because of the hormonal manipulation that's going on. One of the things that's very common in men that is very upsetting to men is gynecomastia, which they start to develop breasts. Women who their breasts start to shrink, so the opposite effect. In men, they start to develop, as was mentioned, the bone loss is common. They get the osteoporosis and pathological bone fractures. Venous thromboembolism for all patients who take estrogen or progesterone becomes a problem, so male and female. All right, nursing implications.
You want to teach the patient.
Nice and loud.
You want to teach the patient not to smoke because of the DVTs.
Mm-hmm.
You want to teach the patients about the expected side effects and the family.
What do you think about the emotional effects of this?
You want to encourage the patient to express their feelings about body changes and refer to a counselor if needed.
Yes. So if you look like a woman all your life and all of a sudden you're starting to look like your husband, do you think that's going to be a little disconcerting? Yeah, just a little bit. So I think you need to address that psychological issue and get some counseling if needed. Absolutely. Absolutely. I mean, it's bad enough you got a cancer diagnosis, right? And then, I mean, one thing losing your hair, but the next thing you're starting to look like a guy. Or you're a guy and you're looking like a woman. I mean, how bad can it get? Yes.
So, there's people who are on these drugs, and let's say they're able to, I know these drugs don't cure their cancer, but let's say they're cured, like forever, how many, some reason. They stop taking these drugs, do you go back to looking like a woman?
Absolutely.
Okay.
Yeah, this is hormonal manipulation. Yeah, this is hormonal manipulation. So once you stop the offending hormones, then you absolutely, you know, the body goes back to its... Yeah, no, they're not permanent. Okay, so we don't have a whole lot of time left, but hopefully you got your grids pretty close to being done, at least one section, maybe more. I had hoped that we could go through the case study that was in your PowerPoints, and I wrote it up in a hard copy. So we can, maybe if you, we're not going to get through it. I'm so silly to think that we did. But here it is in a hard copy. Here you go.
It's not my place, I just think you.
So this is the case study that was on the PowerPoints, and I just put it into a Word document. Oh, it's fine, for us to work on in class and in your small groups. We'll start it and see where we go. All right, so basically what we have here is a 40-year-old woman was admitted to the oncology unit for severe dehydration from nausea and vomiting associated with chemotherapy 10 days ago. She has had 2 adjuvant treatments for breast cancer with adriamycin and cytoxan. She has a Groshon port, that's just basically implanted port that they access, inserted 2 months ago for chemotherapy administration. The healthcare provider orders include strict I&O every 12 hours, may use port for blood draws and IV fluids, call for vomiting or temp of 100 degrees Fahrenheit or greater, D5 half normal saline at 125 milliliters per hour, Zofran 8 milligrams IV every 8 hours, clear liquid diet and progresses tolerated, CBC, calcium level and basic metabolic panel in AM, bed rest with bathroom privileges, knee-high support stockings. What does the nurse understand to be the rationale for each of the provider's orders? So what I want you guys to do is take each order and identify the rationale. Why is the doctor ordering each of these? And you can obviously discuss it amongst yourself at your table. If you know what it is right out of the gate, then, you know, write them down. But basically, why is the doctor making these orders? And you can keep them pretty short and sweet.